Erythrocyte sedimentation rate, ESR. Definition. The erythrocyte sedimentation rate, ESR, is a nonspecific blood test used to measure the rate at which red blood cells, erythrocytes, settle in a vertical tube over a specified period, usually 1 hour. A faster than normal sedimentation rate can indicate inflammation or other medical conditions. Principle. In the presence of inflammation, erythrocytes tend to clump together, increasing their mass and causing them to settle more rapidly. The ESR test measures this rate of settling, reflecting the level of inflammation in the body indirectly. Men 0 to 15 millimeters per hour, women to 20 millimeters per hour, children 0 to 10 millimeters per hour. Elderly, slightly higher values may be seen even without disease. Factors affecting ESR. 1. Increased ESR. Inflammatory diseases. Rheumatoid arthritis, systemic lupus erythematosus, SLE, polymyalgia rheumatica. Infections, bacterial infections, tuberculosis, endocarditis. Malignancies, especially hematologic cancers like multiple myeloma. Tissue necrosis, myocardial infarction, trauma. Other causes, pregnancy, anemia, hyperfibrinogenemia. 2. Decreased ESR, polycythemia, sickle cell anemia, congestive heart failure, hyperviscosity syndromes. Indic ESR is most commonly used to detect and monitor inflammatory conditions like temporal arteritis or polymyalgia rheumatica. Assess the presence of infection, especially in conjunction with other clinical markers. Monitor disease activity in chronic inflammatory conditions. Limitations. ESR is a nonspecific marker and may be elevated in conditions not related to inflammation, like anemia or pregnancy. It should not be used as a standalone diagnostic tool. Other tests like C-reactive protein, CRP, are often used in conjunction to provide more specific information on the inflammatory process. ESR versus CRP. CRP is another inflammatory marker that is often measured alongside ESR. CRP responds more rapidly to inflammation, increasing and decreasing quicker than ESR. While both can be elevated in similar conditions, CRP is considered a more precise marker for acute inflammation. Conclusion. ESR remains a useful tool in clinical practice for detecting inflammation and monitoring chronic diseases, but it must be interpreted carefully alongside other clinical findings and diagnostic tests. Would you The reference values for ESR increase with age, and there are equations used to estimate the upper limit of normal, ULN, for ESR based on age and sex. ESR equation based on age. 1. For males, upper limit of normal ESR unit per hour equal frac text 2. 2. For females, upper limit of normal ESR frax age plus 10. Example calculations. Male aged 50, ESR upper limit equal 52 equals 25. Female aged 60, ESR upper limit 60 plus 10, frac 72 equals 34 hours. These equations provide an estimate of the upper limit of a normal ESR for older adults, recognizing that ESR tends to increase naturally with age. ESR in rheumatology, a key marker. In the field of rheumatology, the erythrocyte sedimentation rate, ESR, is a valuable marker for inflammation and is commonly used to assess the presence and activity of various rheumatic diseases. While ESR is nonspecific, its role is particularly significant in monitoring chronic autoimmune and inflammatory conditions. Common rheumatologic conditions where ESR is used. 1. Rheumatoid arthritis, RA. ESR is often elevated in active RA, reflecting systemic inflammation. It can be used to help in diagnosing the disease in combination with clinical symptoms and other markers, e.g. rheumatoid factor, anti-CCP. Monitor disease activity and response to treatment. Track disease progression or flare-ups. Number 2. Systemic lupus erythematosus, SLE. ESR is typically raised in SLE during active disease phases. However, it is important to note that the ESR may not correlate perfectly with disease activity, especially in cases where CRP remains normal. In SLE, a high ESR may indicate systemic inflammation, but other factors, like infection or kidney involvement, must be ruled out. 3. Polymyalgia rheumatica and giant cell arteritis, GCA. These are two conditions where a significantly elevated ESR is a hallmark feature. Polymyalgia rheumatica, ESR is used to both support the diagnosis and monitor treatment response, with typical values exceeding 50 millimeters per hour. Giant cell arteritis, ESR levels can exceed 100 millimeters per hour. Its measurement is critical in diagnosis, guiding treatment with corticosteroids to prevent complications like vision loss. 4. Ankylosing spondylitis, AS, and axial spondyloarthritis, SPA. In AS and axial SPA, ESR is used to assess systemic inflammation. However, it is less reliable than CRP in these conditions, as not all patients with active disease exhibit an elevated ESR. ESR may also be used to differentiate between fibromyalgia, where ESR is typically normal, and inflammatory back pain in these patients. 5. Vasculitis. ESR is an important tool in diagnosing and monitoring systemic vasculitis, such as granulomatosis with polyangiitis, GPA, and microscopic polyangiitis, MPA. A high ESR can indicate disease activity and help assess treatment efficacy. Limitations of ESR in rheumatology. Non-specificity. ESR is elevated in many conditions beyond rheumatic diseases, including infections, malignancies, and anemia. Lagging indicator. ESR may rise and fall more slowly compared to CRP, meaning that it can take time to reflect changes in disease activity or response to treatment. False positives, negatives. Certain conditions, like early RA or axial spondyloarthritis, may not show a marked elevation in ESR despite active disease. ESR in conjunction with other tests. CRP, often measured alongside ESR, CRP is a more sensitive and specific marker for acute inflammation. Both are used in tandem to get a clear picture of disease activity. Autoantibodies. In rheumatology, ESR is frequently combined with specific antibody tests like rheumatoid factor, RF, anti-CCP, or ANA for diagnostic purposes. Clinical utility of ESR in rheumatology. Diagnosis. While ESR alone is not diagnostic of a specific rheumatic disease, it is a helpful adjunct when considered with clinical symptoms and other laboratory findings. Monitoring disease activity. It is especially useful in chronic conditions like RA, PMR, and GCA to track inflammation and guide treatment decisions. Prognosis. Persistent elevation of ESR may indicate poor prognosis or ongoing disease activity, while normalization often correlates with clinical improvement. In summary, while ESR has its limitations, it remains an essential part of the diagnostic and monitoring toolkit in rheumatology. Understanding its role and limitations helps tailor clinical decisions and improve patient outcomes. Would you like to explore more details about the use of ESR in a particular rheumatologic condition? ESR and CRP in systemic lupus erythematosus, SLE, flare-up versus infection. In patients with systemic lupus erythematosus, SLE, distinguishing between a flare-up of the disease and an infection can be clinically challenging. Both conditions can present with similar symptoms, such as fever, fatigue, joint pain, and elevated inflammatory markers, but the treatments are very different. ESR, erythrocyte sedimentation rate, and CRP, C-reactive protein, play a key role in this distinction, though their behavior in lupus is somewhat unique compared to other autoimmune diseases. ESR in lupus. Elevated in lupus flares. ESR is frequently elevated during a lupus flare-up due to the systemic inflammation associated with the disease. This is largely because lupus involves immune complex formation and chronic inflammation, which leads to increased fibrinogen and immunoglobulin production, both of which increase the ESR. Slow decline. ESR often rises and falls more slowly compared to CRP. This can make ESR useful for monitoring long-term disease activity rather than rapid changes. Not specific for infection. While ESR is a good marker for inflammation in lupus, it is not specific for infection. Both lupus flares and infections can cause elevated ESR, so it cannot be solely relied upon to differentiate between the two. CRP in lupus, low or normal in flares, one of the distinctive features of SLE. Its CRP levels often remain low or within the normal range during lupus flares. This is thought to be due to the fact that lupus involves a more immune complex-driven inflammation rather than direct tissue damage and acute phase responses typically seen in conditions that elevate CRP. Elevated in infection. A key point is that CRP levels usually rise significantly in the presence of an infection. This makes CRP a useful marker for differentiating between a lupus flare and an infection. If a lupus patient presents with high CRP levels and symptoms of inflammation, infection should be strongly suspected, especially in the context of immunosuppressive treatment. Pathophysiology behind ESR and CRP differences. 1. ESR and lupus flares. ESR increases in lupus due to high levels of fibrinogen and immunoglobulins, IgG, which promote erythrocyte aggregation. Lupus often involves a high degree of immune complex deposition, which activates the complement system and causes systemic inflammation. This process results in the chronic, slower rising ESR. 2. CRP in lupus flares. Despite the systemic inflammation, CRP levels tend to stay low during lupus flares. This is partly due to the body's reduced production of interleukin 6, IL-6 in lupus, which is a primary driver of CRP production in the liver. In lupus, the inflammatory response is more immune complex driven, which does not provoke the same acute phase response as in other rheumatic diseases. 3. CRP in infections. Infections, particularly bacterial infections, strongly stimulate IL-6 production, leading to a marked increase in CRP levels. Because lupus patients are often on immunosuppressive medications, they are at an increased risk for opportunistic infections, and a sudden rise in CRP can be a red flag for infection. Clinical scenarios for ESR and CRP in lupus. 1. Lupus flare-up. ESR, often elevated, can range from moderately to markedly high. CRP, usually low or normal. In a lupus flare-up, symptoms like joint pain, rash, fatigue, serositis, or nephritis may worsen. Despite the presence of active disease, CRP remains low because the inflammation in lupus tends not to trigger the acute phase response that increases CRP. 2. Infection in lupus. ESR may be elevated, but this is nonspecific. CRP, markedly elevated. Infection can present with fever, malaise, and worsened lupus symptoms, making differentiation difficult. However, a high CRP level, especially if higher than would typically be expected for a lupus flare, is a strong indicator of infection. This is critical in lupus, where immunosuppressive therapy can mask infection symptoms. 3. Mixed scenario, flare-up with superimposed infection. ESR, elevated. CRP, elevated, but to a greater degree than would be expected in a flare alone. In this scenario, both inflammation from lupus and infection can coexist. Patients may show signs of active lupus disease along with symptoms suggestive of infection, such as localized pain, cough, urinary symptoms, or skin infections. Here, the CRP helps guide the clinician to investigate for possible infections, while the ESR remains elevated due to the ongoing lupus activity. Diagnostic and clinical considerations. ESR and CRP should always be interpreted together in lupus patients, with a heightened suspicion for infection when CRP is elevated. Other tests. Blood cultures, imaging, or more specific markers of infection, e.g. procalcitonin, may be warranted if infection is suspected. Autoantibodies and complement levels. During a lupus flare, there may be a drop in complement levels, C3, C4, and a rise in anti-dsDNA antibodies, which can help confirm the flare if these tests are abnormal alongside ESR elevation. Conclusion. In lupus, the combination of ESR and CRP is crucial for distinguishing between a disease flare and an infection. High ESR and normal CRP, likely a lupus flare. High ESR and elevated CRP suggests an infection, even if a lupus flare is also present. This differentiation is vital, as the treatment strategies for flare-ups, increasing immunosuppressive therapy, and infections, antibiotics, temporary reduction of immunosuppressants, are vastly different. Proper interpretation of these markers leads to more accurate and timely management of patients with SLE. ESR and CRP in rheumatoid arthritis, RA. In rheumatoid arthritis RA, both erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, are key inflammatory markers used to assess disease activity, monitor treatment response, and predict long-term outcomes. These markers provide important information on the level of systemic inflammation, which is a hallmark of RA. ESR in rheumatoid arthritis. 1. Elevated ESR in active RA. ESR is typically elevated in active RA due to the chronic inflammation that characterizes the disease. Inflammation leads to increased production of fibrinogen and immunoglobulins, which cause erythrocytes to clump together and settle more quickly in the test tube. Role in disease activity. ESR reflects ongoing inflammation and is used in scoring systems like the Disease Activity Score 28-28 to measure RA disease activity. In these scores, a higher ESR is correlated with more active disease. Slow response. ESR tends to rise and fall more slowly than CRP. This makes it a good marker for assessing long-term inflammation rather than rapid changes in disease activity. 2. Normal ESR in early or mild RA. Some patients with early or less aggressive RA may have normal or mildly elevated ESR. This can occur even in the presence of symptoms, making it less sensitive in the early stages of the disease. CRP and rheumatoid arthritis. 1. CRP as an acute phase reactant. CRP is produced by the liver in response to inflammation, particularly under the influence of interleukin 6, IL-6. It is a more sensitive and rapid marker of inflammation than ESR and can rise quickly in response to active disease. High CRP in active RA. In most patients with active RA, CRP is elevated, and like ESR, it is also used in scoring systems like DAS28 to assess disease activity. Elevated CRP is associated with more severe disease and joint damage. CRP response to treatment. CRP levels drop rapidly when inflammation is controlled by treatment, making it useful for monitoring the effectiveness of therapy. A rapid reduction in CRP can signal that medications like methotrexate or biologics are working to suppress disease activity. 2. CRP and RA flares. CRP tends to be more sensitive to disease flares than ESR. It rises quickly in response to increased inflammation, providing a quicker indication of worsening disease activity or a flare-up. Clinical utility of ESR and CRP in RA. 1. Diagnosis of RA. ESR and CRP are not specific to RA, but they provide evidence of systemic inflammation. In combination with clinical symptoms, joint pain, stiffness, and swelling, and serologic markers like rheumatoid factor, RF, and anti-cyclic citrullonated peptide, anti-CCP antibodies, elevated ESR and CRP can support a diagnosis of RA. 2. Monitoring disease activity. DAS28 score. The DAS28 score incorporates either ESR or CRP, along with tender joint count, swollen joint count, and patient-reported health to measure RA disease activity. This score helps guide treatment decisions. Low DAS28 indicates low disease activity or remission. High DAS28 indicates high disease activity, prompting adjustments in therapy. DAS28 CRP versus DAS28 ESR. CRP tends to respond more rapidly to changes in disease activity due to the faster kinetics of CRP. DAS28 ESR may lag behind, reflecting more long-term inflammation. 3. Predicting disease progression. Persistent elevation. Patients with persistently high ESR and CRP levels are at greater risk for joint damage, disability, and cardiovascular complications. Studies show that consistently elevated CRP is associated with more rapid progression of joint destruction in RA. 4. Differentiating between flares and infection. RA patients are often treated with immunosuppressive drugs, e.g. methotrexate, TNF inhibitors, which increase the risk of infection. High ESR and CRP can be seen in both flares and infections, but CRP tends to rise more significantly in infections. Flare-up. ESR and CRP will be elevated but often not as dramatically as in infection. Infection. Markedly elevated CRP, along with clinical symptoms like fever and localized signs of infection, would point toward an infectious cause. Limitations of ESR and CRP in RA. Nonspecific markers. Both ESR and CRP are nonspecific for RA and can be elevated in other inflammatory conditions, infections, or even malignancies. Normal ESR, CRP in RA. A small proportion of RA patients may have normal ESR and CRP levels despite having active disease. This can complicate disease monitoring and suggests that ESR and CRP should be interpreted alongside clinical findings and other diagnostic tests. Conclusion. In rheumatoid arthritis, both ESR and CRP are critical for assessing disease activity, monitoring treatment response, and predicting long-term outcomes. While CRP is more sensitive to changes in disease activity and rises rapidly in response to inflammation, ESR reflects chronic inflammation and tends to change more slowly. Used together, they provide a comprehensive picture of inflammation in RA, helping clinicians tailor treatment strategies and improve patient outcomes. Shooting ESR definition and significance. Shooting ESR refers to a sudden significant rise in the erythrocyte sedimentation rate, ESR, typically indicating an acute or severe inflammatory response. This rapid elevation often points to an underlying process that requires urgent attention. Significance of a shooting ESR. 1. Acute inflammatory conditions. A marked and rapid increase in ESR can signal the onset or exacerbation of an acute inflammatory disease. This includes conditions like vasculitis, particularly giant cell arteritis, GCA, where ESR can rise dramatically, often exceeding 100 millimeters per hour. Polymyalgia rheumatica, PMR, a condition closely related to GCA, which also presents with a rapid rise in ESR. Infection. A shooting ESR may indicate a serious infection, especially in immunocompromised individuals or those with chronic diseases. Bacterial infections, abscesses, or sepsis can cause an extreme rise in ESR. 3. Malignancy. Certain cancers, particularly hematologic malignancies, e.g., multiple myeloma, lymphoma, can lead to a sudden and high ESR. The rapid elevation might reflect the extensive inflammatory or immune response associated with malignancies. 4. Severe autoimmune flare. In autoimmune diseases like systemic lupus erythematosus, SLE, or rheumatoid arthritis, RA, a shooting ESR may occur during a severe disease flare. This reflects heightened inflammation due to the autoimmune attack on tissues. 5. Tissue necrosis or injury. Major tissue damage, such as that caused by a myocardial infarction, heart attack, trauma, or extensive burns, can cause ESR to rise sharply as part of the acute phase response. Clinical implications of shooting ESR. Urgent evaluation. A shooting ESR should prompt a thorough evaluation to determine the underlying cause, especially if there are other clinical symptoms like fever, weight loss, pain, or neurological changes. Diagnostic guidance. Although ESR is a nonspecific marker, a sudden spike can help narrow down the differential diagnosis, particularly when combined with clinical findings and other lab results, e.g., CRP, complete blood count. Monitoring disease progression. In patients with known inflammatory or autoimmune diseases, a shooting ESR may indicate worsening disease activity or complications like infection or malignancy. Conclusion. A shooting ESR is a red flag that signals acute, severe inflammation or infection. Its significance lies in its ability to highlight an urgent or potentially life-threatening condition that requires immediate investigation and management.